Okay, good afternoon. Are you all able to see my screen?
Hi, Prof. We can see.
Okay. The problem is I can't see my. Right. What I'll do is I'll just stop sharing and okay. I think times is about 3. 1 more minute to 3. So I will start the class in about 1 minute's time. Are you all? Is it clear? The slides now have re-shared with you all.
It's like small there.
It's a small, is it?
Yes, it is.
Okay. Um, how about now?
Now, okay, there.
Right. I'll just go out and come in because I can't see my slides now. Right. Okay, I'm starting now. Good afternoon and sorry for the delay and change of time. That's something else. Now, shall I proceed? Can you all just put in the chat box? Yep. Right. I'm not professor. I'm just a FMS. Then I'm a general practitioner. And I'm sure you all have done your modules. I think most of you all have submitted your assignments and you'll be marked soon and you'll be able to see your your assignment marks soon. Now I'll just start with the introduction. I'm sure you all have gone through the module. Is there any comment on the module so far? About the module, did you all have any difficulties in accessing the module links? Did you have you find it anything you all find it not up to the standard or you had some difficulty in accessing some of the files? So far, no issues. And what do you all think the module as such? What is your feedback regarding the module? Was it simple, user friendly, easier for you all to see and use? Did you have any problem with the platform? Right, thank you. So now I'm just going to do a revision. So it's going to be interactive, and you can just put in your answers in the chat box, because if not, this afternoon, Sunday, all of us will feel tired and we might not be learning anything. But this, at the end of this session, is not just a revision, but it is something practical which you should be able to apply in your practice. It's just not for the exam purpose. Of course, you have to pass the exam, but the end result is we want you to be really good in primary care, ear, eye, nose, throat conditions. So we as a primary care doctors play an important role by providing comprehensive, coordinated care to the community in a cost-effective manner, because we provide the same quality of what a specialist provide for the initial management. I'm not talking about surgical, because surgical, of course, the specialists have to provide uh, specialized care. But when you're talking about simple conditions like conjunctivitis, throat infection or ear infection, the amount of treatment you're going to be giving will be at par with the specialist. Okay. So that's the importance of our primary care doctors, because after this course, they should be providing good care. So module overview, you have already gone through and you said it was easy. So should have read through the topic, work through the activities, go through the relevant articles, and you should spend 2 to 3 hours per day based on 5 working days if you're preparing for the exam. Because the exam is very simple. You will be having at least 5 questions from ENT and I module. So every module you'll be having something like 5 questions, five. So if you really concentrate, you should be able to answer, because we are not going to ask you uh, questions based on specialists. So it's basically primary care. So the objective of today's revision is also to improve your knowledge, approach, and attitude and skills of family physician. You are a family physician to provide primary, I mean, I'm just stressing primary eye, ear, nose, throat care with superior outcome. That means you should give the best to your patients. And what you should be able to do, you should be able to identify. I'm sure you all know everything, but you need to identify, assess, diagnose, and manage common eye, ear, nose, throat conditions. You see, at the same time, you should also know those chronic, acute, and chronic, and you also need to identify conditions which need to be referred to the specialist. So I have to tell that some of the photos were taken from the internet and some from the National Library of US. Now, this is going to be interactive, so I want you all to be interactive. This 25-year-old patient presents with burning, itching, and mattering of the eyelashes and foreign body sensation to you, and you started about a week ago, and you examine and you find that the eyelid is slightly erythematous, and you see there's thickening, and you can see that yellowish matting of yellowish discharge there, oily thing like a scab there, and you can see the eyelashes are matted together. You can see the telangiectasia of the eyelid margins. What is the diagnosis? Can you just put into the chat box, please? Yeah, that's good. Blepharitis. Yeah, so that's good. Now, the next question is, what is the management? How do you manage? So simple again. Management is why you get blepharitis. Basically, you have meibomian glands. There's a dysfunction of the meibomian glands resulting in the blepharitis and secondary infection. So the scabs are there. It's oily there. You need to take it out. So what you have to do is you give warm compression. So warm compression is basically you take a towel, clean towel, dip in the hot water, and you just apply for a few seconds, take it out. You do it 3 to 4 times a day. And once you do that, the yellowish material becomes softer, and you use a cotton bud, you dip it into baby shampoo, and just you clean the eyelash. Okay. And then once you clean the yellowish, these are all oil that will come out. Then you can give some topical antibiotics. Topical antibiotics you can give bezitracin, fusidin, ophthalmic fusidin, CMC, tobramycin. There are so many in the market. You can give. That is for acute. If it is chronic, you need to give oral antibiotics. If it's not, sometimes the chronic blepharitis takes a longer time to treat, and what you have to do is you need to start them on oral antibiotics. What oral antibiotic would you start for blepharitis? Can you put in the chat box? Yeah, doxycycline, that's the thing. So you give doxycycline for uh, chronic blepharitis. But again, you have to know that this condition is something like acne vulgaris, where you don't give for a short term. If it is chronic, you might have to give it for 2 weeks to 4 weeks duration if it is not responding well. Now, this is a 30-year-old man presents with pain, photophobia, and watery eye discharge in his right eye for 1 day. His vision is normal. What would you ask this patient? Yeah, someone has done. Yeah, yeah. You would ask about history of any trauma, doing welding. Did you do welding? Were you grinding? So usually this happens in industrial activities, especially welding and grinding. So the foreign worker or even locals, I've seen many times, they come out with pain. You need to ask them. Sometimes the foreign workers may not tell. They will just come and say this red eyes, watery. Then you need to ask them questions like how it happened, when it happened, duration. History is very important. From the history, the moment you ask history, they'll say, Doctor, I was just grinding, I was doing welding, I was doing some grazing work, I was cutting grass, and something went into my eyes. So now the next question, as usual, what is the management? How would you manage this patient? Of course, you'll check this vision before you do anything. You check the vision, and then you look for whether it's just superficial or deep. If it is penetrating, of course, you are going to refer the patient. Yeah, vision. And next, what else would you do? You'll do a fluorescent stain, you'll do eye irrigation and fluorescent stain. What else would you do? Would you go to remove the foreign body? Yeah. You need to remove the foreign body. Okay, if you're not quite talented, then you might refer it. How would you remove the foreign body? First, how you will irrigate? Yep. Of course, you're going to irrigate and see whether it's superficial. Most of the time, if the patient is coming to see you because the patient is unable to remove it by washing his eye, he comes to you. So what you do is you have to put local anesthetics. That is alkane, okay, procanamide. They have topical anesthetics. You just apply 2 drops, wait for a minute. Of course, during that time, you do the fluorescent stain, see whether there's any corneal aberration. But if the foreign body was in the tarsal plate, every time it's opening and closing, what happens? It grazes, it causes aberration on the cornea, and then you can see the corneal aberration. If not, what you do is start um, with a cotton bud, normal cotton bud, just remove it, okay? You just remove it with a cotton bud. Fails, use a 21 gauge green needle, put the bevel up, and then slowly scoop it up. Okay, with practice, you will be quite confident to do it. If you're uncomfortable, if you're not competent, of course you have to refer, but you can at least try with, but you must put the local anesthesia. If you don't put local anesthesia, you can't remove it. As you said, you will check the vision, you get the history, check the vision, um, and then put local anesthesia, do the fluorescent stain, and then you irrigate the eye, and then remove with cotton. If you're quite competent, use a green needle, just remove it like that. While in the module revision, I'll show you how to remove it. So removal of foreign body under local anesthesia. For the patient will have pain, you need to give some pain. And post-removal, you want to give topical antibiotics, okay? It can be CMC, tobramycin, fusidin, fusidolmic. So those eye drops can be given. So a 50-year-old presents with eye discomfort for a week. There's no pain, it's normal vision. What is the diagnosis and management? Because this patient's vision will be normal because this has not encroached the visual axis. So, well, very good. I think the others also start typing in. It's the same people. I find it very good. Before I can ask, you all have already done. Yep. What is the treatment? Of course, you have said reassurance and Cheers Natural, artificial thing. Because, see, usually this develops in, again, welders, farmers, someone who's doing outdoor works when they're exposed to UV light. So it starts with a small growth and it just starts growing. So if it's a welder, ask them to use UV protector and then cap if they're farming outside, wear cap and do work. And because sometimes this patient has discomfort, usually they're asymptomatic. But if it gets irritated, I mean, there's some inflammation going on. So that happens when the eyes are too dry. So tell them you will prescribe artificial tears or tears natural. There's so many in the market. Sustain, tears natural, 2 drops as frequent as possible because that's natural tears till the redness goes, till the discomfort goes. If he has pain, then you might want to give them analgesic. If not, no need. Actually, no tablet. And assure them it's a slow growth. It's a chronic granulomatous growth in the eye. It's called pterygium, as you all mentioned. So the treatment is conservative, just natural, UV protection, and PPV. PPE, that means if they are doing welding, they have to have a good eye protection. Now, this is a 25-year-old student presents with right upper eyelid swelling for 3 weeks. It's a unilateral, firm nodular lesion within the tarsal plate. The overlying skin looks a bit hyperemic, okay? It's red a bit. What is the diagnosis and what is the management? Just put in your diagnosis first and we'll see how it is. Yeah. The answer is right upper eyelid chalazion. So you need to know any swelling in the eyelid is called, it is acute, because this one is 3 weeks. If it was shorter, then you can tell hordeolum. In hordeolum, there are 2 types. One is hordeolum interna and hordeolum externa. When you write a diagnosis, we want it to be in full. So it should be right upper eyelid chalazion. So remember that whenever you are writing in your notes or in the exam, if they ask what's the diagnosis, please put the full diagnosis, the side, upper or lower, and what's the diagnosis, and that will give you full marks rather than chalazion. Chalazion is a right answer, but if you start practicing right upper eyelid chalazion, you get full mark. Chalazion, you get half mark. So there's a lot of difference. Your answer is correct. You might think you've done it correct. And why your mark is less, that is the reason. We want you to write accordingly, not only for your practice. When it comes to medical legal cases, you know where, and they will ask, the lawyer will ask, where is which side? Then you might not understand. If it is not recorded and you can't prove in the court of law, then you are liable. Okay. Now the management. Why do you get chalazion? It's because of a result of a chronic meibomian gland obstruction and can be painful or painless. Usually it's painless. When it gets infected, then it's painful. And what is the treatment? Lid hygiene and warm compression. Again, conservative. So they have to be quite, they have to ask them to stop that makeup, eyeliner, all those things. And then warm compression. Again, warm compression should be quite Take the towel, hot water, press it for seconds, take it out, again do it, 5, 10 minutes. Then only it works. It's just not 1, 2 times and doesn't work. You have to do 3, 4 times a day and continue for a couple of days for the chalazion because it's already chronic granulomatous tissue there. Again, it's a bit. And then topical antibiotics only when there is some infection because usually it doesn't work. You can try if it is red, infected, then you want to give topical antibiotic or doxycycline, but most of the time the chalazion with warm compression should subside without any of those things. Having said so, if it doesn't subside, patient comes back to you and says, Doctor, it's not getting better and you're giving me antibiotics, it's not getting better. Then you send them for surgical incision and curettage. It's not surgical incision alone. You need to curate the chalazion because it's hard and you have to just curate it, just like DNC. This patient came with a left upper eyelid swelling for 2 days. Sorry, I just left the upper eyelid. What is the diagnosis? So you can't make a diagnosis, but this again photo tells you 1,000 thing. From the picture, you should be able to tell what is it. Anyone? Let me see. Yeah, that's good. Not bad. Yeah. Left upper eyelid preseptal cellulitis or left upper eyelid periorbital cellulitis. Okay, that's correct. So the picture tells you a lot of things, isn't it? You just if I just give you the case scenario, you might not know, but I'm sure most of you all will be complaining because in the assignment I didn't put in the photos because I wanted you all to think and write. Now, as you all said, this is a preseptal cellulitis. Again, if you ask history, most of the patients might not know. They said, I slept, I got up in the morning, and then got swollen. So preseptal cellulitis are various factors, okay? You can get it because of an insect bite. It can be because of a complication of blepharitis, can be a complication of hordeolum interna or externa. It can be because of ethmoidal sinusitis or frontal sinusitis extending. Most of the time, it's ethmoidal causing preseptal cellulitis. Now, how do you manage? Okay, the preseptal or periorbital cellulitis is an acute infection affecting the eyelid and periorbital tissue located anterior to the orbital septum. The treatment depends on the severity and the age of the patient. Sometimes you see like hordeolum externa, it is very mild, just give topical, but if you see the cellulitis is there, then you need to start them on oral antibiotic. As I said, if they're younger and severe, then you might want to refer them to the hospital for skin because the preseptal or periorbital cellulitis can predispose to orbital cellulitis and other complication. Most of the time, the conservative will be again, can give some warm compression, but if it is hot and painful, then you can ask them to do a cold compression. This is a 45-year-old man presents with a sudden onset of fever and 5-day history of painful swelling, painful swollen right medial side of the eye with reduced vision. This on the medial side, you can see the swelling and you have to think, what do you have in this side? What do you all think? Can you all put in the chat box, please? Yes, there's a lacrimal gland there and there's a lacrimal sac. When it gets blocked and infected, you get left dacryocystitis, left acute dacryocystitis. So the treatment again is inflammation or infection of the lacrimal scab, most often secondary to nasolacrimal duct obstruction. The duct is here, okay? And usually when you put the eye drop, you can feel the taste in the throat. So there's a connection there. So if it is blocked, then you get this. So it can present acutely with pain, swelling, erythema over the medial canthus. Sometimes you can have purulent discharge or chronically with persistent tearing. Sometimes if it is blocked and then there's persistent tearing. Now, the initial management included conservative measures such as warm compression. Again, very simple. You see, um, this is what you have to do. You give warm, it's red, and you just give the warm compression, open up the block so that the discharge gets the opening and then the swelling gets lesser. And may want to start with oral empirical broad spectrum antibiotics. Of course, the patient has pain, you want to give some analgesic, can put some topical antibiotics for the eye. And if say it doesn't get better, you would want to refer them to the ophthalmologist for surgical management. So this is the case scenario for assignment 1. Khalid Hassan, a 12-year-old student presents with 3-day history of swelling on his right lower lid. His mother informs that it started as a small painful area and has gradually become bigger and more painful. Hassan complains of a sensation of fullness and discomfort in the affected eye. He denies discharge, changes in vision, fever, or recent trauma to the eye. He has no significant past medical history and no known allergies. Generally, is healthy. So you examine him and it's quite okay, except and the visions are normal. So we ask for 3 differential diagnoses. This is how the next year your we are preparing you for the part one of advanced training. So this is key feature problem. So if we just want the just answer, we don't want you to write essays because in the exam we don't ask you essays. We just ask you the single best answer, but we are preparing you for the key feature problem, which is going to come in eventually, even for GCFM. So, just for the case, so the case presents with 3-day history of this right lower eyelid. Now, just to refresh, I'll be talking about this again. If you take your eyelid, you just a little bit of anatomy, you have the meibomian glands, and when this gets blocked, you get hordeolum interna. When the other glands, like glands of C's and the gland of mole gets blocked, you get hordeolum externa. So generally, we call them as hordeolum, and we don't use the term STI because STI is a very generic name. Hordeolum is also generic, but it just says there's a swelling or blockage. Now, what are the differential diagnoses of Khalid Hassan? When he's presenting with right eye, lower eyelid swelling. So lower eyelid, same thing. You can have some swelling here because of here. So what are the conditions which can cause swelling? You can just type in. I'm sure you all have done the assignment. Yeah. Lower eyelid hordeolum. Others? Right preseptal cellulitis. Yep. Mumta is quite fast. Yep. Others, please. What are the differential diagnoses for Khalid? I'm sure you all did your assignment. Have you all done the assignment? Sorry, am I asking the question before you all did the assignment? Assignment done, finished, submitted, ready, isn't it? Okay, last, Ahmad Kasifil. Kasifil? Ahmad Kasifil? You want to answer? Okay, ask Kumuda has been quite active. Kumuda, have you done the assignment?
Hi, doctor. Yes, we submitted already.
Yeah, then, yeah, thank you. That's why I'm asking, wondering why others are not writing in. Yeah, I saw everyone has submitted. Yep. So we asked for 3. So what are the 3? So right lower eyelid, hordeolum externa, right lower eyelid, hordeolum interna, right chalazion, preseptal cellulitis, blepharitis, dacrocystitis. These are accepted answers. Of course, the expected answer will be right lower eyelid hordeolum. You have to put right lower eyelid, because this just for discussion, I just put like that. Now you proceed to examine and the findings are as follows. The eye examination shows localized erythematous swelling. You can see the picture there. Localized erythematous swelling. When the right lower eyelid is averted, the swelling is small, firm, and tender on palpation. There's no discharge. The conjunctiva and sclera are clear. But here you can see the conjunctiva is slightly inflamed. Pupils are equal and reacting to light. Extraocular movements are intact. What is the most likely diagnosis? So there's only one answer here. What is the one answer you're going to put? Can you put it in the chat box, please? Only one answer. Right lower eyelid hordeolum interna. Fantastic. Okay, that's it. Yeah, that's the answer. Okay, this is what we want you to answer in the exam. It's the right lower eyelid hordeolum interna. Hordeolum interna externa are acute infection. When the hordeolum interna persists for more than 2-3 weeks, then it turns out to be chalazion. So now, hordeolum is an acute painful infection of the eyelids glands, which I already told you about the meibomian gland of Zill and Mole, and can be located inside or outside. Internal hordeola that do not completely resolve becomes called cysts, called chalasia. External hordeolum are commonly known as styes, but after this, you will just put it as hordeolum externa. Management, again, very simple. If you look at it again and again, it's warm compression, eyelid hygiene, gentle eyelid hygiene with mild soap or baby shampoo to clean the area around the eyelid, because we don't have blepharitis. In case he has blepharitis, the patient has pain, so you need to give some pain relief. You give analgesic, acetaminophen or ibuprofen to start with. Avoidance of eye manipulation. Some patient will be touching and tell them don't manipulate and just attempting to press, push, all those things. Can give some topical antibiotics. As I said, erythromycin, bezitracin, tobramycin, fusidin. You give a follow-up appointment in a week to assess the response to the treatment. If the hordeolum doesn't improve, consider giving antibiotic or referring to the ophthalmologist. You always educate the patient, discuss the signs and symptoms and potential complications such as worsening pain, increasing swelling, fever, vision changes, which would warrant immediate medical attention. Again, this repeat just for you all. So what is the diagnosis? Spot diagnosis, patient has the swelling, treated for hordeolum interna, didn't get better, comes and sees you in 3 weeks' time. The same one which I told you earlier, it is right lower eyelid chalazion. Yep, you're getting it. You're getting it. Try to write the full diagnosis, because in the exam, if you try this, you will get it right in the exam. Because in the exam, you might have put chalazion. So a lot of questions you have put didn't pull full, but your answer is correct. By the end of it, you see your friend would have also put chalazion. The other friend would have put right lower eyelid chalazion. So the person who has put the full would get full mark, and then you get lower mark, and then you write to the examiner asking why my mark is low. I've already done right. So this is the difference. So you need to know why your mark is low. So this is also same, the blepharitis, another case of blepharitis. You can see all those things. There's the oil there. And again, this is a condition of small trauma there causing periorbital cellulitis. Okay, there's a small cut there, and this has led to the lower eyelid preseptal, left lower eyelid periorbital cellulitis. Yeah. Now, any questions so far? Any questions? Am I going fast? Going too slow? Too boring? Is it easy to follow? Do you find it difficult? Right. Because I'm not going to go deep into the pathophysiology and all those things because that is up to you all to read. So I just give you the basic things so that you work on it. Now, when we come, we expect you to know how to approach a patient with eye symptoms, especially red eye. There's conjunctivitis. There are a lot of conditions that can cause red eye. You need to know about eye discharge or conjunctivitis causes eye discharge, foreign body, keratitis, all those things. Eyelid swelling, which I just showed you, few of the samples, examples, like hordeolum interna, externa, chalasia, and blepharitis. Eye pain is also very important. Foreign body, chemical, chemical conjunctivitis, trauma, and also acute close-angle glaucoma. They're all present with eye pain, vision loss, especially in glaucoma, cataract, and retinopathies. I will not be able to cover all, but I will cover those things in the module workshop. This is just a revision post completion of your module. So you should be very knowledgeable in the following eye conditions. Again, diseases of conjunctiva and cornea, diseases of the sclera, the lens. Need to know a little bit about retinopathy and glaucoma, vitreous and of the retina, not too much. Eyelids, of course, these are the things you see very frequently. Lacrimal apparatus, you need to know because this is again you see diseases of the orbit. We are talking about orbital cellulitis. It's a medical emergency, and periorbital cellulitis, which we see in our practice, and ocular emergencies and ocular injuries and emergencies. If they come to your practice, you need to able to give the first aid and refer the patient to the hospital. So this is a 38-year-old female presents with 3-day history of watery, itchy left eye. You take history. Of course, you need to take history, examine, vision is normal. You examine the eyes are red a little bit, both bilateral red conjunctiva and history. There's no exposure. You said, then you ask them, yeah, my child had also red eye and now it's better. I brought you to see. So what is the diagnosis? Bilateral conjunctivitis. Okay, this is an example of red eye. Very simple. I know it's a very simple day-to-day things, but these are the things we see in our primary care. We don't see complicated cases. If the bilateral conjunctivitis worsens and then his vision is affected, of course, then you refer the patient. In the history, I think you need to know, I will re-emphasize in the module workshop, if the patient, you need to know the red flags. One is blurring of vision, history of trauma, history of wearing contact lens, and acute onset. You need to be quite careful. It means if some foreign body injury, you need to refer. You need to take further history. What is the most appropriate management? So this pink eye, okay, the most common are viral, allergic, and bacterial. And the redness is due to the dilatation of the blood vessel, is usually accompanied by increased tearing and mucoid discharge. So this is again from the internet. So the treatment is again conservative. In this case, when it's itchy, you don't give warm compression. Here you give cold compression. Ask the patient to use cold. Okay, cold water, towel in the cold water and just apply. That will work. But if you put hot water, warm compression, the redness will get worse because the redness is due to the dilatation of the blood vessel and usually due to accompanied increased tearing and mucoid. So if you put warm compression, so the blood vessel gets more dilated and gets more redness. So for conjunctivitis, when they present, just ask them to use cold compression, okay? And sometimes in the logbook, when you all submit, I see they will put CMC eye drop. Conjunctivitis, clear conjunctivitis, as far as possible, do not give antibiotic unless you right there, you suspect bacterial conjunctivitis, because previously I marked a logbook, they'll put viral conjunctivitis, and then the treatment part, they put CMC eye drop. So you will be marked down. So as far as possible, you will never go wrong if you put there conservative management. I'll give tears natural. I give artificial tears. Yeah, artificial tears, and you will give so vasodilatation. You see, you give something to vasoconstrict. So you give vasoconstrictor, topical vasoconstrictor like tetrahydrozoline. Okay, tetrahydrozoline can constrict the red eye. The moment you put within 2-3 minutes, within few seconds, the blood vessels gets constricted, and then the redness just disappears. And then later you can follow up with Cheers Natural. Cheers Natural is methyl cellulose. Okay, in the exam, if they ask methyl cellulose, remember methyl cellulose is the content of artificial tears. So conjunctivitis again, because it's a very common, you have to tell it can, sometimes if it's allergic, you have to remove the allergens. Usually it can take 1 week to 3 weeks. And treatment includes artificial tears for lubrication 4 times a day or up to 10 times a day with preservative-free tears. Cold compressions with wet wash cloth to the periocular region may provide symptomatic relief. So that's why I said cold compression. Preventing the spread of the infection to the other eye or other people requires patient to practice good hand hygiene with frequent washing and avoidance of sharing towels or linens and avoiding touching your eyes. If you touch, wash your hand. This is a 38-year-old mechanic presents with sudden onset of red eye, a severe cough and cold, there's no pain, and his vision is normal. What is the diagnosis and what is the management? You look at it, of course, you're going to take the history, you're going to ask them how it started, when it started, is there any pain, is there any itchiness, is there any eye discharge, was there any trauma? Of course, any eye condition, you need to take history because I want to emphasize you need to write a history there because every red eye, you need to put there whether there was any trauma, any wearing of lens. Okay, right. So this is red eye subconjunctival hemorrhage. Yep. So this is a subconjunctival hemorrhage. Very good. Now, what, and if they put it there, if they had put their right eye, you need to put in the right subconjunctival hemorrhage. Now, what is the management like? Yeah, conservative, okay? Good. But you need to explain the patient that you have taken the history and then you have examined eye. You say your vision is normal and your anterior chamber is normal. There's no blood in your anterior chamber. Your vision is clear, but your conjunctiva is red. That is because of the conjunctival vessels have given way and there's bleeding there. And that could be because of your severe cough. So don't worry. And you say, there's no need for any treatment. What you can do is you can put some cold compression at home, take a towel, cold water, and apply 3 to 4 times a day. I will give you artificial tears that is to soothe your eyes. And you come back and see me if you have, yeah, it will take some time for this is quite bad. Sometimes very minimal subconjunctival hemorrhage will recover within 10 days to 2 weeks. But this might take some time. So you need to educate the patient. If not, the patient will say, Doctor, it's still red. Should I go and see the ophthalmologist? They'll be quite scared because it's quite scary. So subconjunctival hemorrhage is a common ocular condition. It's defined by extravasation of the blood beneath the conjunctiva, producing a sharply demarcated red patch on the scleral surface. The condition is usually painless, does not impact vision, and often resolves within 1 to 2 weeks, making it frequent but benign cause of ocular disease. One important thing is when a patient is met with a motorbike accident or road traffic accident comes with subconjunctival hemorrhage, then what do you suspect? Can someone tell me? Because this was one of the exam questions last time. What would be the cause of that subconjunctival hemorrhage in a patient with road traffic accident? Yes, must rule out fracture base of the skull. Okay, and this condition, if there you suspect, you can't see the upper. If you can't see the upper border, you need to refer to the neurosurgeon because you have to see the Glasgow Coma score and see his vision, and then refer him to the neurologist. Okay, of course, you want to refer to the, even though it is red in eye, you would want to refer to the neurologist and to rule out fracture base of the skull. As you all mentioned, it's conservative, typically resolves within 4 to 14 days. Patient should be reassured of the benign condition. Artificial tears may be recommended for symptomatic relief of irritation. Patient should be advised to avoid rubbing or strenuous activity because that will again cause bleeding. Sometimes don't give NSAIDs because NSAIDs again can aggravate the bleeding because they are. Now, here's another condition of red eye. This 28-year-old lady presents with pain and swelling that just developed 2 days ago. You ask the history, it's just spontaneous. There's slight pain, vision is normal. There's not much of a cheering, but she's feeling uncomfortable. So you can see there's a swelling in um, the eye. So you all want to type in the diagnosis? What is the diagnosis? Yeah. It is episcleritis, okay? So, and nodular scleritis is also a differential diagnosis. Yeah. So that's good. Majority of you all are getting the answers. I think this module has helped you all. I suppose a lot of you all are typing in the answers quite quickly and fast. That's fantastic. I'm quite happy that you are able to diagnose these things. Now, the next will be again management. You see, the management in primary care is so simple. Management, how do you manage this patient? The answer is yes, left episcleritis, left eye episcleritis. What is the management? How will you all manage in your practice? Yeah, it's conservative, okay? Usually, in key feature problem, what we expect is we ask you all, is it, you have to write in pharmacological and non-pharmacological. So one of the candidate has said non-pharmacological. So most of the episcleritis are mild, transient, and resolve without intervention within 2 to 21 days. Supportive treatment with refrigerated artificial tears, because basically you need to put something cold inside, and patient may not require. If their condition is severe, then you want to refer them. If you think they have autoimmune disease, and if you think it is nodular scleritis, the vision is affected, pain is getting bad, uh, then that's a red flag. Okay, remember, pain, severe pain, because conjunctivitis, usually patient do not have pain. But if the patient has pain, has blurring of vision, remember that's a red flag. This is the same condition. Earlier, same patient came with this about, say, 1 year ago. This another patient with 30-year-old man present with right eye swelling with which is painless. It has been there for 3 months. The vision is normal. It doesn't have any pain. There's no eye discharge. You take history, it's a welder. So you see the difference between the previous and this one? Yeah, that's good. Yeah, Pingicula. Fantastic. This group, you are able to diagnose. This is spot diagnosis, okay? The diagnosis is Pingicula. And what is the management? Again, very simple. The Pingicula is a benign, common degeneration of the conjunctival tissue. It appears as a gray, white, yellow mass in the bulbar conjunctiva. It presents in people exposed to wind, dust, ultraviolet light, and working outdoors for a long duration, and also with patients who does welding, grinding, and all those things. Usually, it causes cosmetic complaints. Treatment-wise, there's no treatment. If the patient has, because it's asymptomatic, you don't have to put anything. If the patient says, I've got irritation, then you give tears natural. So this is the same follow a condition, pterygium you saw, but this patient's vision is altered, okay? This pterygium is just affecting the visual field. So this one, primary care, you tell you have to go for surgery. Now this 72-year-old man presents with clinic with gradual loss of vision in the right eye for past 1 year. What is the diagnosis? You can see it. Wow, it's glaring just looking at you. What's the diagnosis? Right eye. Cataract. Yep. Yeah. Majority I've got it correct. So it's very simple, straightforward, and you can see it's just white. But if it has happened in a child, what would you think of? If this same condition presents in a child, what should you think of? Yeah, retinoblastoma. Congenital cataract, yep. Not gonorrhea, you'll think of retinoblastoma. Yeah. Remember that if it is a child, usually they don't come to you because it will be screened in the hospital itself. But if you tend to look and they miss and comes and the child has strabismus, and sometimes they might just present with orbital cellulitis, think of retinoblastoma as a medical emergency, you need to refer. Cataract is not a medical emergency, but you need to still refer to the specialist for cataract extraction. That's phacoemulsion. Nowadays, what they do is they just use sound, they just break the cataract into small pieces and then suck it out, and then they put intraocular lens. So you need to be quite good in eye examination, conjunctival and corneal body removal under local anesthesia, eye irrigation, fluorescent staining, and fundoscopy. I'm not going to go through this because there'll be a practice workshop, practical session where I'm not sure they're teaching you all that, but I will tell you how to do about this in the module workshop. Okay, anyway, it's here. This is fluorescent stain. How many of you all have used fluorescent staining? How many of you all have done? Kumuda, yeah. Kumuda, are you working? You're quite, yeah. Noor, Malini, KK. Oh, right, that's good. Maha. Oh, okay, there's a lot of you. Yep, that's good. A lot of GPs will have. Okay, now you need to know how to use the fluorescent stain. That's good, fantastic. Because the previous batches all earlier, some of them didn't know. But now you need one of the things you need to have in your practice is fluorescent stain. So how to do it? You instill the fluorescent dye by moisturizing with sterile fluorescent strip with 1 or 2 drops of sterile saline or topical anesthesia. What I do is when I'm going to examine, I usually put topical anesthesia, 2 drops into the eye so the patient gets uh, doesn't feel, because a lot of times we want to rule out corneal aberration. And I use the same topical anesthesia on the fluorescent, just a drop, and I'll just bring down the over the lower eyelid, ask the patient to look up, I'll retract, then I'll put it down, and I'll ask the patient to open and close for a few seconds, blink for several minutes, and then the whole thing will disperse, and you can see a beautiful abrasion, ulcer, or a foreign body there. So that's all for eye, and I've got another half an hour to talk about ENT. Approach to ENT conditions. So in primary care, what do we see? Patient comes with ear pain, ear discharge, tinnitus, hearing impairment, vertigo. That is for ear. Also for the nose, he present with rhinitis, epistaxis, blocked nose, polyps, and those things. And throat is very common. The most commonest is the sore throat and pharyngitis and tonsillitis. So you should be quite knowledgeable on this condition. Of course, this is not so common, but cerumen, cholesteatoma, hearing loss, foreign body, labyrinthitis, vestibular neuronitis. Well, you need to know, but it's all come under vertigo. Otitis externa is the common one, and otitis media, these are quite common. So the common ones, you should be quite familiar and knowledgeable. So this was the other case assignment. Siti Maria, a 3-year-old child, is brought to your mother for 3-day history of fever and ear pain. Siti has been crying, has been tugging her right ear. She has a running nose and mild cough. There's no history of ear discharge. Siti has not been eating well and crying more than usual, especially at night. Siti has no significant past medical history and is up to date with her immunization. She is irritable and refuses to be examined. The temperature is 38, heart rate is 150, 112, respiratory rate is 22. Of course, I should have put in the um, picture, but then what are the 3 most likely causes? Okay, so most 3 likely causes will be anything to do with pain. What other conditions can cause pain? Otitis externa, right? Acute otitis media, otitis externa, mastoiditis, eustachian tube dysfunction, foreign body, pharyngitis, tonsillitis, rhinitis. All these things can cause, and the accepted answers, most of the accepted answers are 1, 2 are the most accepted answers. If you have written all the other up to 6, we still give you mark. Now this is the picture of the image of the, you examine and then you look into the, you do a otoscopy, and this is the picture. So what is the diagnosis? It's right acute otitis media. Okay, now what is the treatment? So it's acute. So right ear otitis media is correct, but if you put right acute otitis media, would be fantastic. Pharmacological and pharmaco, yep. Kumudam, yep. What would you give? Because if you look at the antibiotic stewardship, watch for, you can wait and see. And if the child is irritable, quite toxic, 2 years, 6 to 2 years, you can start on oral antibiotic. Okay, amoxicillin is the drug of choice, or augmentin. Observation, a period of watchful waiting without immediate antibiotic treatment. This allows for spontaneous resolution of the infection. You need to give some, because the child is in pain, you give some pain relief. Antibiotic is often recommended for moderate to severe cases, young children under 6 months of age, and those at risk of complication. Commonly prescribed antibiotic include amoxicillin and amoxicillin clavulinate or cefuroxime. Need to follow up the patient to look into complication. Because one of the complications of acute otitis media is mastoiditis. Sometimes if you don't treat properly, can even go to the brain, can cause meningitis, brain abscess. Not common nowadays. Okay, these are some of the things. Yeah. So again, this some of the slides will be shown again in the module workshop. So this patient presents with severe pain, tenderness on pressing the tragus. When you press here, the patient says pain. And what is the diagnosis? If you look carefully, there's redness, a little bit of swelling, and you see here where I put the mark, there's some yellow spot there. That's a pustule sort of thing. Yeah. Right, otitis externa is good, correct. Yep. Pinacellulitis. Okay. Have you heard of furunculosis? Yep. You press here over the triggers, they have pain usually. Furunclosis, yep. That's furunclosis. Furunclosis, acute presentation. The moment you touch here, the patient will, and when you want to put the otoscope, the patient will have severe pain. And you see inside, your external canal inside will be normal because the problem is outside. No, otitis externa is the correct answer. But if you want to be more acute, more specific, it's called furunclosis. Just like furuncle anywhere, because it's just infection of the hair follicle. You can see the pus there. For this, you give warm compression because you want the pus to come out. You want the swelling to, you want there's, what we say is, there's a pinpoint, there's a pus point there. You want the pus to come out. So you give warm compression with moist cloth to the ear several times a day. For pain, you give some analgesic. It could be paracetamol or ibuprofen. Oral antibiotic like flucloxacillin, cefalexin are often prescribed to fight the infection, especially if it is severe. In this case, you can see it's a bit like red here. So you want to give, if not, just give topical fusidine, topical bezitracin. That should be good enough. But if it's quite an elderly person, you can just use you can use a sterile needle, fine sterile needle, and just put a local application and then just prick, the pus comes out, the patient will feel better. It's just like any abscess. So this is a patient, again, present with severe pain and itchiness in the ear, and there's some discharge. Presence, say the patient says, I had this ear pain for a couple of days. I came, I took medicine, not getting better. For the history, well, I went for swimming. And if you look at it, you can see spores there. Okay. So what is the diagnosis? Yep, good. Automycosis. This is automycosis, okay? Right. So when you have automycosis, okay, you need to do debridement. So there's no point giving them topical antifungal because you see, the topical antifungal will not penetrate deep inside because the infection is quite deep. So you need to do debridement. How you do debridement? You need to do microsuction. How you do microsuction? You need to have a suction machine. If you do not have, do not do syringing because this syringing will worsen the condition. Do intense debridement and cleansing. That means you just suck it up. And then you put topical antifungals such as clotrimazole or miconazole or tolnaftate. They're quite safe. And for pain, you give some analgesic. For itchiness, you give some antihistamines. So, and remember automycosis or any otitis externa with discharge, you need to remove the discharge. You need to remove the whatever is inside the ear canal because without removing it, the patient will not feel better. He'll come back to you again or might go to another doctor. If you can do it, then you don't have to send to the ENT specialist. Not with automycosis. Automycosis is it can happen in even normal individual, but if it's a diabetic patient, then you can get malignant otitis media. Not in normal, unless and the other condition is if it's immunocompromised, treatment is ineffective. That's why I said you need to do debridement of the external canal because if you don't do, patient will not recover. This is another patient. This is a complication of otitis media. If you don't treat otitis media, remember the city. If you didn't treat them properly, just gets complicated. You get otitis. This is mastoiditis. Acute mastoiditis is a complication of acute otitis media. Antibiotics are centerpiece of mastoiditis treatment. Additional measures include meningotomy, tympanostomy, tube placement, and mastoidectomy. The majority of cases of patients with acute mastoiditis, you need to refer them to the ENT specialist. Okay, you can give them oral analgesic, you can start them on antibiotic, but immediately refer them because they need to be hospitalized because they get more complications. Because mastocytitis is a complication, so you don't want the child to have brain abscess or meningitis. Refer them. So you need to be quite good in otoscopy, tuning fork test, Dick's Holpik maneuver, and Epley's maneuver, and interpreting audiograms. So you need to be quite familiar with sore throat, cough, dysphagia, hoarseness, or oral problems and upper airway in throat. So this is a simple case which we see very regularly in our practice is sore throat. And if it is a young child, you look into the CentOS criteria. This is basically pharyngitis. Again, it's conservative treatment. But if it is a child, look into the CentOS criteria, and then you treat them with the antibiotic of choice is oral penicillin followed by amoxicillin or augmentin. If they're quite sensitive to it, then you start them on erythromycin. If you leave them, then some of the patients who present with sore throat, with fever, and you look into the throat, the tonsils are enlarged, the uvula is soft palate is also swollen, and this acute tonsillitis. Again, most of the time it's viral, but if you think it's strep infection, look at the CentOS criteria and then start them on antibiotic. If not, just again conservative treatment. Again, if the tonsillitis is not resolved and the patient comes on with worsening of the sore throat, with hot potato in the throat or cannot talk properly, and you see such a massive swelling there, can't swallow, is a bit toxic, think of what? What is this diagnosis? What could be the diagnosis? Yeah, quinsy. It's not epiglottitis, it's peritonsillar abscess. You need to refer this patient. It's a medical emergency. You need to refer the patient to the hospital because you need to do surgical intervention to take out the pus from the tonsil. Immediate referral. Antibiotics won't work. Of course, you need to give antibiotic, but surgical drainage is the main thing to do. So, as I said, the treatment is penicillin. If they fulfill the CentOS criteria, if they're allergic to penicillin, you can start with erythromycin or azithromycin. So I'm sure you all are well versed with the examination of oral cavity and oropharynx and throat swab because we just came out of COVID, so majority will be quite competent in doing throat swab. Comes to nose, very common is running nose, blocked nose, nosebleed, sinusitis, smell disturbances, and snoring. So you should be quite knowledgeable in managing epistaxis, foreign body, nasal polyp, and rhinosinusitis. So when the patient comes with bleeding, you have to ask them to press on the soft part of the nose, okay? Pinch the soft part of the nose, put the head forward like this, avoid tissues, and avoid nose blowing, okay? You tell them. Get the patient lean forward with the arms on the desk and use both thumbs to apply. Okay, like this, okay? You can lay like that. Easy. First, ask the patient to open the mouth and breathe, okay? You close the mouth, close the nose, patient will collapse. So you need to compress for 10 to 15 minutes because then only it works. Just press and open, no, it won't work. So nasal packing, okay, this is how you use a ribbon gauze. You soak it with 1:10,000 epinephrine, and then you just do layer by layer, okay? That's nasal packing. But if it's an elderly person who comes with persistent bleeding in the nose, it doesn't stop with pinching, doesn't stop with antinasal pack, then think of posterior, this bleeding from the posterior, you need to do a posterior nasal pack. So this one you can't do, you need to refer. Usually majority of the cases we see, the bleeding is from the anterior part, okay, Kesselbeck's plexus. So posterior one, posterior bleeding epistaxis needs to be referred to the hospital. Some patients who present with daytime sleepiness, his wife complains of snoring and sleepy, weighs overweight, blood pressure is high, sugar is high. So you think of obstructive sleep apnea. He might be snoring because of obstructive sleep apnea. So you need to send them for sleep test and then CPAP. A little bit on audiogram. We don't give you complex audiogram. From the history itself, you will know what is the diagnosis. If it is elderly person, patient with gradual progressing hearing loss for past 3 years, his bilateral tinnitus and which annoys him, his ear canal and eardrums are normal. You do a tuning fork test and you have a sensory neural type of hearing loss. Then the audiogram shows that. So usually normal audiogram, normal one, people should be able to hear within 0 to 25. So the graph should be this level. So these are low frequencies and these are high frequencies. So the patient is able to hear in the low frequencies, but when it goes to the high frequency, it just goes down. So this is a case of presbycusis, okay? This is the former one is presbycusis. But the moment they say it's a 45-year-old male or someone working in the industry and complains with reduced hearing, tinnitus, reduced hearing, and it's been also gradual. Then you do again otoscope, ear canal is normal, eardrum is normal, and you do a tuning fork, shows air conduction is better than bone conduction, and you think it's sensory neural. The audiogram shows the lower frequency again, it's normal, then dips at the 4,000, that's high frequency and goes up to 8,000. So you see that in presbycusis, it just goes down. It doesn't recover. While noise-induced, it just dips down at 4,000. And I'm not sure why, but this is the natural pattern, because the pattern of noise-induced hearing loss. And if you see a pattern like this, just diagnosis will be noise-induced hearing loss. Noise-induced hearing loss again, and then presbycusis, there's no treatment. You need to, for noise-induced, you have to tell the patient wear proper PPE, avoid working in a noisy environment, and don't listen to loud noise. And if he has a hobby of playing drums, avoid it or lessen it. And this is a notifiable. This is noise-induced hearing loss to Department of Occupational Safety Health. So most of the slides are used from this Slides Go. So you all can go to Slides Go. It's a free, you get free PowerPoints and it's quite nice. And that's the end. Right. Now, that's all for now. And I will see you all again, the module workshop. That'll be a couple of months or next year. And we'll see how it goes. Okay. Do you, do you think the revision was helpful to you all? I think most of you all are quite good. I saw a couple of people were able to answer and type in very good. That's fantastic. So if you look at it, ENTI, they are subspecialty. But you see, that's the great part of this being a primary care doctor. You are able to manage, okay, all these conditions in a quite efficient and cost-effective manner. Right. Any questions? Because you see, if it was just theory, if I'm going to give you explanation, you may not understand. A picture tells you 1,000 words. So instead of talking, I just put you all pictures and photos and explain, and this is what you're going to see. And if you're interested, I will show you some photos. If you're interested, not many. These are some of the photos I have. I'll just share some of the photos I have with me. Okay. Are you all able to see?
Yes, doctor.
This wax, earwax. Are you all seeing the entire thing, or what are you all seeing?
Entire photograph, nine pictures.
Oh, okay. Okay, you see this acute otitis externa. The first, this is normal, but he has an infection. But this one is acute otitis externa. You can see the redness there. Okay, and this is a post removal of the wax. I removed the wax, and then this is the picture. This is the normal one, and this is the wax here. This is a wax. This is a normal ear drop, and these are wax. I'll just show most of it are wax, and this just want to show you all some the normal eardrums. This is how a normal eardrums looks. Just want to show you some perforations. Just a minute. Okay, this is central perforation. You can see the central perforation here. Are you all able to appreciate the central perforation?
Yes, doctor.
Yeah, that's central perforation. So in perforation, you have anterior, posterior, central. So anterior and central perforations are quite safe perforation. But if you have posterior perforation or attic perforation, then it is not a safe perforation. So I'm going to stop sharing, and I think next time I will just take the ones which one I want to show, because this was a revision class I didn't do. Oh, for hordeolum, see, for blepharitis, you give doxy, while hordeolum interna or externa, you can usually it's again conservative. But if you want to give, you can just, because they are basically staphylococcal or strep, so you can start them on penicillin group of drugs, cefalexin, augmentin. This antibiotics will work for hordeolum externa or interna. That was for doctor. You asked me, who's the doctor? Yep, Arvind. You can give cefalexin, okay? Cefalexin, augmentin. But I prefer cefalexin or cefuroxime for if they have, you see, hordeolum interna externa, if they have periorbital cellulitis, you start. If not, just topical antibiotic should be good enough. Right. Any comments on the presentation? Any deficiency need to be improved? You all think there's anything I should improve on the module or on the presentation? The presentation, this is just a glimpse of what I'm going to talk on the workshop. Some of it will be repeated again, but it'll be more photos, more cases. Right. If everyone are okay, you can leave. I will join you all again. I will start the next session for the other group later. That is 4:45. So I'm going to leave now. If you all don't have any questions, you all can leave. And thank you for joining. And it's really great to know that a lot of you all are quite well versed with the common ear, nose, throat, and eye conditions. So you're just not only preparing for your exam, but preparing for a lifelong practice in as a primary care doctor. Okay, don't stop here. Just go on to do your ATF, an advanced training program, pass the exam, become a family medicine specialist. We need a lot of family medicine specialists in primary care. We need about 8,000, as you all know. Proceed and complete the course and continue studying. And for the exam, It's all single best question. What I'm trying to tell you is a lot of you all fail because you all don't put enough effort. Um, and majority of them, year after year after year, we see a lot of failures. It's not because the exam is tough, but the problem is majority of you all not putting enough effort. You all think it's going to be easy, so you all don't prepare, or you're preparing in the last minute. No, you will never, you cannot pass the exam. You have to think you're sitting for MRCP. So these exams are all at that level. They are not very simple, easy questions. They can be quite tough. Some questions can be tough. So you need to put in effort to prepare for your exam. When are you all sitting for the exam? Next year, is it? Yeah, next year.
Yes,
So
sir.
if it's next year, please start preparing now. That means you spend 1 hour, just 1 hour enough. See, if you have a thing, so one of the books I would recommend use Family Medicine Review. Okay, this is the book here. Can you all see?
You know,
Swanson's,
sir.
okay. Swanson's Family Medicine Review. This book is quite useful. I just type in, if you all don't have, I'm sure you all have a series of MCQ questions. I just type in, you just use, if you all can get it from your friends lah.
Ada.
Swanson.
Saya ada kelas. Saya tak ada, saya tak ada.
Swanson's
Call lain
Family Medicine Review. It's a problem-based approach. Okay, this is actually for Australian board exam. I mean, American board exam. They use this, and I find it quite useful. If you all want, because it's just all you have to do is there's a case, and then there's an answer, there's an explanation. Just go through this. It can be very useful for you all, not only for GCFM, but when you are going for ATFM. And the old version, you can get it online for free, if I'm not mistaken. Some of your seniors, those who are in the KKM, just find out from your seniors whether they have this book and you can borrow from them. Right. Bye bye for now. Are you all able to see my slides? Yeah. Yeah. Good afternoon. I'm going to start now. And so it's going to be an interactive session. So each question I'm going to please put in your answers in the chat box so that it is quite live. We can learn, because at the end of the day, you're not only preparing for the exam, but you're also preparing for your practice to be a better doctor. Um, and and as you all know that we play a very important role, and by providing comprehensive and coordinated care in a cost-effective manner. So be attentive and be interactive. That's what I'm trying to say. You have gone through the module, you have read through the topics, you have worked through the activities, and you have gone through the relevant articles, I suppose. And right now, you need to prepare for your exams in May. Spend 1 hour at least, go through some of the questions, past year questions, and start preparing. Don't do last minute, because it's all single best answer. So it's basically knowledge. There's nothing to apply. There's no applied knowledge. It's just knowledge only. So please start practicing from now onwards. Don't wait for the last moment. So what is the objective of this module is to improve your knowledge, approach, attitude, and skills of a family physician to provide primary care primary eye ENT care with superior outcome. That means after the module revision, you should be able to provide good, efficient care to your patients. Okay. You should be able to identify, assess, diagnose, and manage common eye, ear, ENT conditions seen in primary care. It can be acute or chronic. At the same time, emergency conditions you need to be able to identify and manage. So some disclosures, some of the pictures and case scenarios have been taken from the following websites. Okay. Now this patient who presents and comes to see you tomorrow morning, and he presents with burning, itching, matting of the eyelashes, and he has a foreign body sensation. You look at the eye, there's slight erythema of the cornea, conjunctiva, and you see the eyelashes are matted. There's yellowish discoloration, discharge, they are scabbed, they're oils, basically thickened oil. So this has been there for a couple of days. He comes to seek advice from you. Can you all just put in the chat box what is the most likely diagnosis? Yeah. So only one have answered. Delila, that's correct. Blepharitis. Shyamala, Luzana, yep, blepharitis. That's the correct answer. That's good. And how do you manage? You do warm compression, lead hygiene. You use a cotton bud, soak in the baby shampoo, and just do gentle shampooing of the eyelid, and that will loosen up the warm compression will loosen up the oil. And when you do use the cotton bud, it will help to clean up the space there. You can give topical antibiotics like CMC, bezitracin, fusidine, tobramycin. So these are the topical antibiotics you can give. Topical steroid ointment for recalcitrant cases to be done by the specialist. Okay, we don't do it. If it's not responding, then you have to refer. But for chronic blepharitis, you can start them on oral antibiotic. What is the antibiotic? If the patient comes back to you again and says, "Doctor, I'm not feeling better," it's still there, even after warm compression, lead hygiene, and topical antibiotics, what would you give? What antibiotics would you like to give? Yep, doxycycline, that's correct. So just like acne, fibroiditis can take a long time to get better. So you give doxycycline for 4 weeks. So if it's recalcitrant, okay. Now this 30-year-old patient presents with pain, photophobia, and watery eye discharge in the right eye for 1 day. His vision is normal. What is the diagnosis and management? What is the diagnosis? Can you see the patient comes? You need see any eye cases. You need to get history, proper history, when it started, how it started. Did anything go inside? You do wear contact lens? Did any chemical go in? Is your vision blurred? Is there any pain? So the red flag for red eye is pain and blurring of vision and trauma. So these are red flags. Okay. Once you ask them, they will tell you, "Oh, yeah, doctor, I was grinding and something went in my eye." You can see that foreign body there. Can you appreciate the foreign body here? Are you all able to appreciate this foreign body? Yeah. So the management is when the patient comes, you have taken the eye vision all recorded. What you do is you put local anesthesia. The patient will be in pain, so you can't do much. So you put a local anesthesia called amethocane, procainamide, they have a special preparation for topical anesthesia. Apply that, and then you do a fluorescent stain to make sure there's no corneal injury. And you just do you can do a eye irrigation because usually the patient would have done eye irrigation. As a first step, do eye irrigation. Use a cotton bud to try to remove the foreign body. If it's quite superficial, it'll come out. But if it doesn't, we're quite confident. Use a 21 gauge needle and try to scoop it. Okay, just scoop the thing out. Okay, don't ensure you don't have tremors or just scoop it out. The foreign body will come out and the patient will be quite relieved of the pain. So the treatment is removal of foreign body under local anesthesia. You give analgesic and topical antibiotic. So this is another patient who comes with eye discomfort for a week. There's no pain, vision's normal, and he gives history of I do a lot of grinding works in the grinding and welding work. Okay? What is the diagnosis? It's very simple, isn't it? Right. That's pterygium. Correct. Answer is pterygium. So usually pterygium is a fleshy growth there. Management-wise is usually conservative since it's not affecting the vision. That's why it's very important in eye you take the vision. Okay, the vision 6/6, and there's no pain, just discomfort. You just educate them there's a fleshy growth. It's called pterygium and it's harmless, but you need to protect your vision. And for discomfort, I'll give you tears natural. Just give them artificial tears. That's methyl cellulose. Tears natural UV protection and PPE because sometimes they need to wear proper PPE. If not, it gets worse. So this student who presents with right upper eyelid swelling for 3 weeks, unilateral, firm, nodular within the tarsal plate. And you see there's a little bit of redness. So if you look at the duration is 3 weeks. It's shorter, you call hordeolum. It's 3 weeks. What is the diagnosis? 3 weeks of eyelid swelling. What do you all think? Yeah, that's correct. Chalazion. So the answer is right upper eyelid chalazion. So you always try to write in right side. Which side is affected? Right side. What is the problem? Is a chalazion. So, and which part is affected? Right upper eyelid. So try to write in full right upper eyelid chalazion so that you get full mark. The right chalazion is correct, but you get half mark. From now onwards, start writing it. In the exam, in future, probably next year, I'm not sure whether it's going to be key feature problem like, but at this point of time, it is single best answer. So a single best answer, you don't have to keep writing the full because the answer will be there. You just tick. But in future, in case you're going to go to advanced training program, you need to write the full answer, right-sided upper eyelid chalazion. Then you get full mark. Usually the treatment is conservative. You give lid hygiene and warm compression. Warm compression you have to do 3 to 4 times a day. Every time you do, at least do for 5 minutes. You can give topical antibiotic or anti-inflammatory, but most of the time it won't work unless it is rate like a earlier case. Because if it is earlier case, it's quite rare, then you give it this quite a cold case, the antibiotics won't work, but you can continue with warm compression. You can give a course of antibiotic like doxycycline because sometimes it could be arising from blepharitis. And if it doesn't get better and for cosmetic reason, or if the patient is saying, I feel irritated, then you send them for INC. It's called incision and curettage. So this patient came with left eye, upper eyelid swelling for 2 days. And you take history, you say, I'm not sure, doctor, it just started. I got up in the morning and it is swollen. You need to ask them, got pain. Most of the time, patient may or may not have pain. Is your vision blurred? If you check, most of the time it's not affected. So there's no mild pain. There's vision is normal. Again, you treat them and review them and see. What is the diagnosis? Anyone? Put the diagnosis, please. Yeah, that's preseptal cellulitis of the left upper eyelid. Okay, you can see there. So treatment again is you can have pharmacological and non-pharmacological. Usually think of pharmacological and non-pharmacological because to the patient you're going to tell, give some warm compression, need to give some analgesic for pain, and if it is quite severe, if it's a child and the temperature is high, then you want to start them with antibiotic. But if it's a child less than 1 year, you might think of referring him to the hospital because he might need IV antibiotic because they are not so their immunity is not so good, so the condition might worsen. Lumps, okay. This is a 45-year-old man presents with sudden onset of fever and 5-day history of painful, swollen right eye, redness, and reduced vision. Okay, there's a swelling there in the medial canthus. Can anyone think what could be the diagnosis? So I'm going to give case scenario and the images so that you can see as many as possible. Yeah. This is dacryocystitis. Actually, the image is in the left eye, so it's wrong. So left dacryocystitis. And the treatment, dacryocystitis is inflammation or infection of the lacrimal sac, most often secondary to nasolacrimal duct obstruction. Can present acutely with pain, swelling, erythema over the medial canthus and pleural discharge, or chronically with persistent tearing and intermittent discharge. The treatment again is very simple, pharmacological and non-pharmacological. Initially is warm compression, oral empirical broad spectrum antibiotic, analgesic, and topical antibiotic drop. It is very mild and just watery. Just ask them to do a curricular massage. Usually in children, they come with watery and swelling. Just do a massage here like this. That's called curricular massage. This is the assignment 1, ophthalmology. Khalid Hassan is a 12-year-old student present with 3-day history of swelling on the right lower eyelid. His mother informs that it started as a small, painful area and has gradually become bigger and more painful. Hassan complains of a sensation of fullness and discomfort in the affected eyelid. He denies any discharge, changes in vision, fever, or recent trauma. There's no past significant medical history or allergies, generally healthy. An examination is well, mild discomfort due to eyelid swelling and pain. His temperature is normal, his heart rate is normal, his blood pressure is normal, and the vision is normal. What are the 3 differential diagnoses for Khalid's presentation? What do you think could be the reason for his uh, right lower eyelid swelling? So when there's a right eyelid swelling, think whether it could be rising. So any swelling in the eye could be dacryocystitis, or it could be raising from one of these glands, okay? Meibomian gland, any blockage and swelling, or this from this gland of Zeiss or gland of Mohr. So these are, so meibomian glands is any of this blockage can give rise to the swelling. So for this Khalid, what do you all think is the differential diagnosis for that patient? So the differential diagnosis include right. So this is the lower eyelid. So the answer should be right lower eyelid. Hordeolum could be hordeolum externa, hordeolum interna. You can put the chalazion, preseptal cellulitis, blepharitis. Any of this, you'll be given mark. But the expected answer will be if you have put all first 3, then that would give you better good marks. Okay. So you proceed to examine the eyelid, you rub and you see a localized tender swelling which is red in color. Okay, and the conjunctiva is slightly red. So you can see the swelling here. So now what is the diagnosis? What is the most likely diagnosis for Khalid? This is called hordeolum interna. The hordeolum interna arises because of blockage of the meibomian gland. So it can be located in, so any swelling in the eye can be inside or outside, as I mentioned, depends on the glands affected. It's the meibomian gland usually for hordeolum interna, and for hordeolum externa is the glands of Zeiss and mole. And the treatment is again warm compression, eyelid hygiene, and pain relief. You need to give some acetaminophen or ibuprofen and avoid and so the eye manipulation. Don't ask them to rub the eye. Okay, you have to educate them. You can give some topical antibiotics like erythromycin, methotrexate, CMC, or fusidine creams or tobramycin. There's so many in the market. Give them an appointment to come back in a week's time. If the condition worsens and develops severe periorbital cellulitis, then you might want to consider system oral antibiotics or referral to ophthalmologist. So this is another case of chalazion, okay? Another case of blepharitis. This is another case of, you can see the lower eyelid is all swollen and there's a small wound there. So this is a periorbital cellulitis. So periorbital cellulitis is the infection of the anterior portion of the eyelid without the involvement of the orbit, that is anterior to the orbital septum. The symptoms include eyelid swelling, redness, warmth, and tenderness. And you can see it's red, swollen, and usually they don't have proptosis. And they can move, their vision will be normal. But in a child like this, you might want to try a course of antibiotics and topical antibiotics and analgesic. Ask them to come back in 2 or 3 days' time and give them advice. If it gets worsened, come back immediately and refer them to the hospital for IV antibiotics. So you need to know about red eye discharge, eyelid swellings, and eye pain and vision loss. And you're expected to be knowledgeable in diseases of the conjunctiva and cornea. There is conjunctivitis, keratitis, scleritis, diseases of the lens like cataract. Diabetic retinopathy, you need to go know glaucoma a little bit. These are the disorders of the eyelids, which I showed you just now. Lacrimal gland apparatus like acrocystitis, which I showed you. Very important is ocular injuries and emergencies, which you need to manage before you refer them to the specialist. Any questions so far? Any questions? Am I going too slow, too fast? Are you all able to follow? All left still there? Okay, that's good. Interesting. Well, still there. Right. It's a very common red eye condition. I just said about red eye. I'll be talking about few red eye conditions. This some of the slides, majority of it will be again discussed at the module workshop. This is a 38-year-old female presents with a 3-day history of watery, itchy left eye. You ask them when it started 3 days ago. Is that itchy? Yes. Is there watery discharge? Is there any pain? No pain. You have blurring of vision? No blurring of vision. You examine the red and the conjunctiva are red. What is the diagnosis? You'll type in what is the diagnosis. This is a very common condition you see in primary care in your clinic. You all want to type in the diagnosis. Right. The answer is correct. As I said, both the eyes are red. So you need to put the bilateral conjunctivitis. So the conjunctivitis most of the time is viral or bacterial. So ask them again is It's conservative management, pharmacological, non-pharmacological. Non-pharmacological is hand hygiene. Important is hand hygiene, not to rub the eye, don't share the towels. And pharmacological, there's not much. If they have itchiness, you can give them antihistamines. And for the eye, just give topical, just natural. And you can give vasoconstrictors because the blood vessels are dilated. You can give tetroxymethazoline. So that vasoconstrictor can help to reduce the redness. It's not scary. Can give some just natural or methyl cellulose that can be help in relieving the discomfort in the eye. Remember, the red flag for red eye is you need to ask them whether you have pain, you have blurring of vision, you wear contact lens, was there any trauma? There's nothing there, then we can take it as quite not a serious condition. Very important, you need to educate them so you can prevent the spread of infection to the other eye or other people requires. Practice good hand hygiene with frequent washing, avoidance of sharing towels or linens, and avoiding of touching the other eye. This is a 35-year-old mechanic presents with sudden onset of red eye, a severe cough and cold. There's no pain. The vision is normal. So what is the diagnosis? Diagnosis is basically subconjunctival hemorrhage. Okay, this is a very common ocular condition defined by extravasation of the blood vessel beneath the conjunctiva. This is the conjunctival vessels give way, producing a sharply demarcated red patch on the scleral surface. That is quite severe condition. This picture looks severe, but sometimes the subconjunctival hemorrhage can be quite mild. Sometimes patients with conjunctivitis, they rub the eye so much, so bad that they also can have subconjunctival hemorrhage. The condition is painless and does not impair the vision. So very important, as I said, you need to ask the vision. Is your vision normal? Was there any trauma? Is there any pain? Nothing. Just reassure the patient and tell them it will disappear within 1 to 2 weeks, depending on the severity. The mild, usually 1 to 2 weeks. Quite severe might take 3 or 4 weeks to subside. Tell them, reassure them it's benign. You don't have to go to specialist. So the treatment again is cold compression and recommend symptomatic relief. And you should ask the patient not to rub the eye, strenuous activity, and also manuals can aggravate the bleeding. This patient present with the left eye nodular swelling on the conjunctiva that developed about 2 years ago. You ask them, do you have any pain? Well, I have very mild pain. You have blurring of vision, no blurring of vision. You examine and then you notice this swelling there. What do you all think this is? Can you all type into the chat box? Correct. Cases put there. Red eye episcleritis is the correct answer. So this case of episcleritis, which are mild, transient, and resolve without intervention within 2 to 21 days. Supportive treatment, again, very simple. Okay, cold compression, artificial tears. So you put the artificial tears in the refrigerator, in the fridge, and then use it 2 to 3 times. If it's quite red, then you give vasoconstrictor, oxymetazoline, tetrahydro. Yeah, there's a vasoconstrictor for the eye, just use that. Vicin eye drop is the commonly available over-the-counter medication for vasoconstriction and reducing the redness. So this is the precursor for the episcleritis. Usually they present with painless swelling, and which usually is harmless. And sometimes when they do welding, then they get some discomfort. This is called, you all want to type in? What is the diagnosis? You want to type in, right? You're not sure? Okay, this is Pingicula, okay? The previous batch was quite quick. And treatment again is conservative. There's no treatment, but if the patient has yeah, tension, yeah, spingicular, Renu, tension I've put in is spingicular. Yep, that's correct. So conservative treatment, okay? It's a benign common degeneration of the conjunctiva. It appears as a gray, white, yellowish mass, swelling, nodule. The bulbar conjunctiva presents with people exposed to wind, dust, ultraviolet lights, those who do welding, and usually is cosmetic. Treatment is, as I said, if it is uncomfortable, just give tears natural. This is a pterygium which is blocking the axis of vision axis, so it has impact vision. So this one, not conservative, but you need to refer the patient to eyes ophthalmologist for removal of the pterygium. This is pterygium affecting the vision. And this elderly person who comes to the clinic with gradual loss of vision, the right eye for 1 year. So what is the diagnosis? You can see the left eye is okay, the right eye, you see the white thing. This is called cataract. I'm sure you all have seen cataract. And the treatment is phacoemulsion. You have to remove, you need to dissolve the cataract, remove the cataract. Nowadays, they don't do cataract extraction, but they do phacoemulsion. I mean, they dissolve the cataract with cataract, and then they wash it out, suck it out, and then put the intraocular lens. If it is in a child, newborn child, if they have cataract, think of congenital cataract or retinoblastoma. Both the condition has to be referred to the eye specialist. So you need to know how to examine, need to know how to remove corneal foreign body, and eye irrigation and fluorescence staining and fundoscopy. Nowadays, a lot of KKM have fundus cameras, so you can refer them to the fundus for fundus camera for diabetic patient. Fluorescence staining is a very simple point of care test which can be done in primary care. The test is it's a small strip and it's used to assess a cornea, especially patient with trauma, to rule out corneal aberration or ulcer or foreign body. All you have to do is put 2 drops of topical anesthetic and then wet the fluorescein with 1 drop of topical anesthetic or saline, and then avert the eyelid, put the fluorescein in the lower eyelid, ask the patient to blink few times, and then the dye will spread equally, and then you can see whether there is a ulcer or aberration or a foreign body. And that's all about eye. Now I'm going to go to ear, nose, and throat. So very common in the primary care is ear pain, ear discharge, tinnitus, and hearing impairment and vertigo. And you need to know a little bit about each, but cerumen is very common. Polycythemia is rare, especially in diabetic. Hearing loss may come. Foreign body is very common. This basically vertigo, also patient comes with vertigo is very common. Otitis externa, otitis media are very common in primary care. So you need to know well about the cerumen, hearing loss, foreign body, vertigo, and otitis media and externa. So this is the case assignment about the girl with acute ear pain and has been tugging the right ear. And we asked you what is the most likely diagnosis. We asked the 3 differential diagnosis. Patient with ear pain, always think there is some infection or inflammation. So could it be a otitis externa? Could it be otitis media? Could it be a foreign body? Could it be an insect bite? Could it be a furunculosis? Or is it a referred pain from the throat, tonsillitis, dental caries? You have to think all these things. But if you had put the first 3, you get full mark. The others, you still get mark. And this is the picture of acute otitis media. You can see the redness, inflammation on the eardrum, and it's bulging. So this is acute otitis media. The treatment for acute otitis media, again, depending on the severity, okay? Usually, With a mild child is not feverish, you just give a period of watchful waiting without immediate antibiotic treatment. And sometimes the patient condition will solve. Just for pain or fever, you can give some paracetamol. Now, antibiotic again, because of a lot of antibiotic abuse, you can wait and see. But however, if the temperature is quite high, if it is a child, I usually within 6 to 2 years, I would start an antibiotic. And antibiotic of choice is amoxicillin or augmentin or cefuroxime. You need to follow up because sometimes you have to tell the patient that the middle ear infection, autoimmune, the middle ear infection, there can be fluid, there can be pus, and then the eardrum can perforate, and you can get pus coming out. Same ear pain. This patient comes with ear pain, and it's just started 2 days ago. And you examine, you just touch the tragus. It's very painful. This is an example of otitis externa. But if you look closely, there is a yellow spot here. This furunculosis, basically infection of the hair follicle. There's a pus point there. Treatment is again warm compression. You need to give some analgesic. Can give topical antibiotic first, but if there's severe infection and there's a cellulitis, then you start on oral antibiotic. If you see a pus point there, you can take a swirl needle, small, fine swirl needle, just make a small prick, pus comes out, and the patient will be relieved. And you put the antibiotic cream there. One antibiotic, you can put CMC, fusidine, bezitrocin, tobramycin. Usually patients with, when they come with ear pain, itchiness, and discharge, when you open and use an otoscope, you can see spores like this. You think of automycosis. So when you think of automycosis, there are two things. One is spores, one is candidiasis and aspergillosis. Okay. So treatment is you need to remove the debris there. You need to do microsuction. You just remove the microsuction and then you give topical antifungal. You don't give systemic antifungal, but give topical antifungal like clotrimazole, miconazole, tolnaftate are potential safe choices for treatment of automycosis. And even if you suspect with perforated eardrum. Very important, you have to remove this debris there. If you don't, even if you give antifungal, patient will come back to you, because the eardrop will not be able to penetrate deep inside. One of the complications of otitis media is, if it is inadequately treated, is mastoiditis. This is the patient who treated and didn't get better with otitis media, comes back with irritability, fuzziness, and lethargy, fever, and pulling the ear and ear pain. So you look into the ear, there's otitis media, and then look behind, there's a swelling and inflammation and redness. This is acute otitis, this is acute mastoiditis. This child has to be referred to the specialist. You can start antibiotic and then analgesic and refer the patient. Don't keep it. So you need to be quite competent in otoscopy, tuning fork test, Dick Solpic manual, Neplis manual, and interpreting audiograms. Audiograms, we won't be asking you too much. Just you need to be knowing a little bit. I'll show one or two audiograms. And coming to throat, I think very common you see is cough and cold, hoarseness of voice, other problems like epigenoma. In case of hand, foot, mouth disease, you have oral ulcers and upper airway obstruction like foreign body. And you need to be quite familiar with pharyngitis, tonsillitis, laryngitis, and benign and malignant lesions of the pharynx. But this one, patient might just, usually they'll come with sore throat and it's not getting better. They themselves will go to the ENT. But if you treat and the condition is worsening, always think of malignant lesions of the pharynx and larynx. Very common in primary care, patient comes with fever, cough, sore throat, and then you look into the throat. You see this type of this condition. This is acute pharyngitis. Most of the time it's viral, so it's always symptomatic treatment with gargles and analgesic, okay? And if you suspect infectious mononuclear, they have rash, they have enlarged spleen and liver, you need to give them leave because there's a risk of splenic rupture. Pharyngitis, the other common condition which presents with sore throat is enlarged tonsil. This is a case of tonsillitis. Eh, So, sore throat then progresses to tonsillitis. You need to use the CentOS criteria to look whether this patient needs antibiotic for strep infection. If doesn't fulfill the CentOS criteria, then you don't have to give antibiotic. But if you fulfills the CentOS criteria, then you start them on oral antibiotic. The drug of choice is penicillin group of drug, and then amoxicillin. If it's allergic, you can start them on erythromycin. If the tonsillitis is not well treated, can progress to severe, more swelling, more pain, hot potato voice, and temperature spiking. And you open the mouth, you see such a bulging mass, and this is peritonsillar abscess or quinsy. Yeah, very good. Neurolita, very good. That's quinsy. Quinsy, again, is a medical emergency. I mean, ENT emergency. You need to refer the patient to ENT for incision and drainage. Of course, they need antibiotic, IV antibiotic, analgesics. So the most common antibiotic of choice for sore throat, if you think it is bacterial strep infection, is penicillin, oral penicillin. If they are allergic to penicillin group of drug, then you start them on azithromycin, erythromycin, clindamycin can be used. So these are the expected thing you need to be competent with. Now coming to the nose, the common presentation is nosebleed, obstructive sleep apnea, running nose, sinusitis, smell disturbances, and snoring. And you need to be quite knowledgeable in managing patients with epistaxis, foreign body, nasal polyp, and rhinosinusitis. Now we'll look at epistaxis. This is one of the common conditions seen in primary care. So the patient comes with epistaxis. These are the things you need to do. You pinch the soft part of the nose. So this is the soft part of the nose, not upper. This is the soft part. You just tilt the head downwards, not straight. Don't use tissue and then remove. And ask the patient not to blow the nose. And ask the patient to lean forward, the hand on the arms of the dash, and apply top like that. You can apply like this. You need to apply the pressure for 10 minutes. So even after applying for 10 minutes, it doesn't subside, then you can think of doing nasal pack, anterior nasal pack. You just take a ribbon gauze, soak it with 1:10,000 adrenaline, and just pack layer by layer. Most of the epistaxis starts from the Kesselbach's area. Okay, this is the anterior part. Sometimes the elderly people with hypertension or anything, you pinch, you do anterior nasal pack, it doesn't work. Always think whether the bleeding is from the posterior. So especially elderly people with recurrent episode of epistaxis and it's an active bleeding and it's not getting better. So you need to perform posterior nasal pack and refer to the ENT for endoscopic examination. Sometimes patient with snoring, daytime sleepiness and snoring, think of obstructive sleep apnea. So this patient needs to do sleep assessment, sleep study, and then refer to the ENT for sleep study as well as see whether he needs CPAP. There's a controversy of using CPAP nowadays. So again, coming to audiogram, again, it is you just look at the picture, you will understand. Normal audiogram, normal person should be able to hear. This is a low frequency, this is a high frequency. So they should be able to hear within 0 to 25. So if you look at this guy, his audiogram in the low frequencies are normal, okay? He's able to hear at 25, 15, 20. So in the low frequency, he's able to hear. But then when it goes to high frequency, 2000, 3000, 4000, it just keeps on going down. So now look at the stem. 78-year-old retired aircraft engineer present gradual loss of progressive hearing loss past 3 years. Bilateral tinnitus, which annoys him. His ear canal, eardrums are normal. You do a tuning fork, air conduction better than bone conduction. You think it's a sensory neural deafness. You refer him to audiometry. The audiograms comes like this. So once you see, you just look at the stem, whole person, what could be the thing pressed by acousis. Okay, sensory neural deficiency just goes down. Higher frequencies are affected. And then if it is a mid-aged fellow who's working in exposed to noise, he comes with again hearing loss and tinnitus. Think of noise-induced hearing loss. The thing about noise-induced hearing loss is the patients, as I told you earlier, low frequencies will be normal. He'll be able to hear normally in low frequencies, and then and then at higher frequencies it goes down and then recovers at 8,000. So this is a typical picture of noise-induced hearing loss. So if at all they ask, they will be asking only these two. They won't ask much. So just think about presbyacusis and noise-induced hearing loss. Presbyacusis just goes down, while noise-induced, it goes down at 4,000 and then recovers. And that's it. You can get good slides as slides go, which is quite reasonable. I'm going to stop sharing. I'm going to and see whether you all have any questions. Yeah. Is there any questions? Was the topics covered? Was it adequate? Do you all think it is inadequate, boring? Or is it quite helpful to you all? Because I'll be talking about again in the module workshop before your exams. There'll be a module workshop. We'll just do a revision and just will be much more. Some of the slides will be again shown to you all. All awake. Too fast, too slow, boring. You learn something you can apply tomorrow in your clinic. So, just a word of caution. See, a lot of them come. I say, of course, your ultimate aim will be passing the exam, but at the same time, you need to have your knowledge on this common ENT eye condition. Now, if you for passing the exam, don't come unprepared. Okay. So there's a question, all cases of perforated TM need to be referred? No, not all conditions, because acute otitis media, they come, there's you treat them, see them. In the module workshop, I'll be talking to you about the safe and unsafe perforation. The safe perforations are in the anterior and central. Unsafe are usually in the posterior and attic region and the margins. And those perforations you need to refer. It is quite safe, small, because there are criteria for referral. Small, anterior, central perforations, you don't have to refer because they will heal. Large perforations, which are in the posterior attic region because of cholesteatoma, are marginal, will take long time, then you have to refer. Presbyacusis depends, yep. Say elderly patients, they have hearing impairment. It's quite severe and affects their activities of daily living. And sometimes when they can't hear, they get irritated and angry with the people around because they think that you're talking something and they can't understand, they'll get angry. So those cases you can refer to the ENT for hearing aid. But it depends. If the patients refuse, we can't do much. We can't force a patient, but you can give, as a primary care physician, you can give suggestion, do your part, say, okay, I'll give you, or you can go and see an audiologist. Okay, they want to see a ENT, say, okay, you go to the audiologist and check how bad is it and see whether you need a hearing aid. Now, coming back to the preparation of the exam, I usually tell the candidates, don't come for exam without any preparation. Don't think it is GCFM is simple or this primary care will be easy to pass. No, no, no. Always remember this is again equivalent to the family medicine course, MRCP level. So the questions will always be at the level of MRCP or family medicine specialist exam. Don't come unprepared. Please do study every day. Spend 1 hour, not for ENT, for the entire thing. So that when you come for the exam, it's easy. You see, when you really study well, these exams are all single best answer. It's knowledge based. If your knowledge is good and you can think, there's no way you can fail. Usually we expect 80 to 90% to pass, but unfortunately what's happening is only 30 to 40% are passing. I keep on telling, study well and pass the exam. Don't fail and come and say the exam was tough or the examiners failed them. There's nothing. It's all automatic. It's all marked by the computers. You do well, you tick correctly, you will pass. Please do study. Spend 1 hour from now onwards for all the modules. Don't study last minute. You will never pass. And year after year after year, we are getting 30, 40% passing because they all study at the last minute or they don't study and come thinking it's a very simple exam. No, please remember GCFM is not a simple exam. You are preparing you all to be a family medicine specialist. So we won't be asking simple questions. Of course, the ENTI, if you have really followed my follow my workshop, you will be able to answer most of the questions. Usually, ENTI modules, the answers, the questions, majority are able to answer. But of late, I find majority are also not answering well for ENT and I. I'm not sure why. Please do study well, spend some time. Okay, any other questions? If not, I'm going to close the session. Thank you for joining this Sunday. Shall I close the session if there's no question? So I will close the session. Thank you very much. Ahmad Kasifillah Mustafa has been there from last time. He is on the computer, closed everything, and I don't know whether he's attending or not.